was seeded an oculoplasty interest in all of us in LF and as well as in Kerala. Her topic is on orbital mass lesions.
I will just go through some of the lesions that we have encountered. It does not include all the lesions that only some of them. The time was only 6 minutes or 8 minutes. So according to little flower statistics a long back, so inflammation, lymphoid tumors are the most common. And this was a case of mass lesion presenting in a man who was working in the Gulf. And CT scan showed he had there were parts of bone missing in the sinuses, and he had gave a history of fest done. So, and this was a very hard mass which was removed. The ENT surgeon removed the ENT part, and we removed the orbital part. And it was a fungal granuloma, aspergillosis. It's a very hard mass usually. So, sclerosing idiopathic orbital inflammatory disease is a new entity where you get again a very hard mass which is adherent to the structures. It has calcification and it erodes the bone, but the movements are well preserved. So it can occur even in small children. So this is a IgG4 positive orbital mass. So histopathology will show fibrosis and lymphoplasmacytic infiltration. But there are certain criteria for diagnosing a IgG4 related orbital disease. It's called IgG4-ROD, related orbital disease. The serum IgG4 should be raised. There should be more than 50 IgG4 positive cells per hypound field. So this is again a 45-year-old male who presented with the proptosis of the left eye. There was a mass in the superior orbit. So according to the CT, what is the diagnosis? What is the diagnosis in the CT? It's a molding mass, lymphoma. I thought it's a lymphoma, but the histopathology showed emperipolysis, that is presence of intact lymphocytes within the cytoplasm of the histiocytes. So the pathologist gave a diagnosis. It was CD68 and 600 positive. The pathologist gave a diagnosis of Rosai-Dorfman disease, and it was published along with the RCC people. So this was a case of a very bone eroding mass. This was many years back. The CT is not that clear. Bone eroding mass with a soft tissue component. The bone zygoma is almost totally destroyed, and there was a discharging sinus at his lateral canthus. So this was biopsied, and it turned out to be orbital tuberculosis, and it completely resolved with anti-TB drugs. This case again was a non-homogeneous mass in the lacrimal gland area. So this was biopsied, and there was palisading pattern necrosis, and there was suspected fungus. We sent it to Shankar Netralaya. The fungus was negative, but when they did a PCR visit, it was positive for orbital tuberculosis. So orbital tuberculosis can present in many ways. This was again a hard mass in the inferior orbit. That is why the orbit is called a Pandora's box, because when you open up anything, the diagnosis can be anything. Again, a hard mass producing a hypertropia, and the histopathology showed non-necrotizing inflammatory cells. That means it is not a tuberculosis. And there were Langerhans giant cells which are seen. It was an orbital sarcoidosis, and we had to give him systemic steroids for a long time, nearly 1 year, in collusion with the pulmonologist for the lesion to disappear. And this was a cyst, a hard, thick-walled cyst with layered contents, and it presented as an abscess. Somebody had did an IND for him already. It was a dermoid, a deep dermoid in the medial orbit. So this lady presented with a swelling in the temporal area. She also had a history of some surgery which was done many years back, and CT showed a mass, a cystic mass, which was the Hounsfield units were consistent with the fat in the orbit, and it was through the tunnel in the lateral wall. It was going to the temporal area. So this is a what type of dermoid? Dumbbell dermoid. It's a dumbbell dermoid. It's there inside and also outside. superior orbit with bone excavation, and it was a huge mass in a young child. Bone excavation means it has been present for a long time. As also the small mass in the anterior to the septum in a young boy. It was a schwannoma with positive antony B and A cells. This lady presented with a huge mass behind the retrobulbar, which is nearly pushing the eye out, and turned out to be a fibrous histiocytoma, or it's called a solitary fibrous tumor now, SFT, solitary fibrous tumor. This was a bilateral lacrimal gland mass. This was a young lady who was lactating, and she had a 1-year-old child. There were foam cells with lymphocytic infiltration and two-tone giant cells, which are characteristically seen in xanthogranuloma. Which is a xanthogranuloma. The mass will be slightly yellowish in color. So that is the indication. Xantho means yellow. A bone eroding mass in a child, you would have seen Dr. Santosh's slides. It was there were plenty of eosinophils, plasma cells, degenerated blood elements, and giant histiocytes. Eosinophilic granuloma, which is a localized form of Langerhans cell histiocytosis. Again, this child came with a history of fall. You can see the abrasion on the skin. There was a hard mass in the inferior orbit extending to the cheek. It was biopsied, and it was a primary neuroectodermal tumor. All these diagnoses are given by the pathologist. We can just biopsy and either excise the mass completely if it is completely excisable. If it's a friable mass, just do an incision biopsy. This was again a bone eroding mass in the left orbit, superior orbit, and it turned out to be again a primary neuroectodermal tumor. The patient has expired. He was treated at Vellore. A unilateral proptosis with a retrobulbar mass in a young child. Always suspect rhabdomyosarcoma or even any of the hematology tumors. So always do a fundus examination, look for rod spots, etc., and do a peripheral smear to rule out leukemia. This was a punched out lesion in the bone with the soft tissue component in an old lady. What is it, punched out lesion? It was CD138 positive. It was a plasmacytoma, which is a localized form of multiple myeloma. Again, a squamous cell carcinoma which is extended to the orbit. The treatment is excenteration. This was a molding mass in the superior orbit, and what will be this thing? It's a lymphoma. After radiation, the mass is completely resolved. Such cases, you just need to do an incision biopsy. Again, it can occur in the lymphoma can occur in the lacrimal gland alone. Bilateral lacrimal gland masses, you should think of differential diagnosis: lymphomas, leukemia, sarcoidosis, Sjogren's disease, tuberculosis, Wegener's orbital inflammatory disease. These are all the things which should go through your mind if there is bilateral lacrimal gland enlargement. A rounded mass with bone excavation in the lacrimal gland fossa. It was a pleomorphic adenoma of the lacrimal gland. It will be confined to the lacrimal gland fossa. A mass which is extending beyond the lacrimal gland fossa with bone excavation. It was an adenocystic carcinoma of the lacrimal gland. Again, a lacrimal gland fossa mass which we thought was a pleomorphic adenoma with recurrent episodes of pain, redness. There was a bone excavation but no bone erosion. This turned out to be, there were sheets of abundant eosinophilic cytoplasm, microsis with eosinophilic secretion, and this turned out to be oncocytoma. So some rare tumors also occur. You need a good pathologist to diagnose them. Cavernous hemangioma can present as a retrobulbar mass, especially in females. It can increase with pregnancy, and it's a very fleshy tumor which can be very easily removed. But a hemangiopericytoma can be very huge, and it can be benign or malignant. If it's malignant, you do not leave anything behind, or after that you have to give radiation. A young child with rapid increase in proptosis with subconjunctival hemorrhage and multiple fluid levels and cystic lesions seen in the orbit could be a lymphangioma. Lymphangioma is a clinical diagnosis. You need not always biopsy it. Multiple cystic level cysts will be seen. Microcysts and macrocysts will be seen.